This conference will now be recorded.
Hey, good evening, everyone. I want to thank you for joining us and this lecture series that we're working to put together with our team here at Reconstructive Orthopedics. For anybody joining us that has not met me, my name is William Smith. I go by Will. I'm one of the newer hand surgeons that has joined Reconstructive Orthopedics in the last year. And I am originally from the Delaware County area in Pennsylvania, so not too far from here. Trained locally in this area at Jefferson and Temple, and did my upper extremity fellowship at the University of Pittsburgh. So I have been local for a long time, and I was happy to return this way. So I'm going to be talking about something very common, one of the most common things that comes into my office, and that is aggravating people. And really the focus of this talk is managing hand numbness and tingling, really in the new normal that we are experiencing in this pandemic. And really my goal was to kind of mimic what an initial office visit would be for somebody that has been struggling with hand numbness, tingling, aching pain in the hand. And really, if they were to come into the office and leave their quarantine, what would I say to them? What would that visit be like? And what suggestions could I make to hopefully help to manage those symptoms, or determine whether or not we need to be a little bit more aggressive and move forward with some other specific treatments. So that's kind of going to be the outline for today. So we're going to talk about the main causes of numbness and tingling, specifically carpal tunnel syndrome is a common term that a lot of people have heard of, but we're going to talk exactly about what that means. Something less commonly known or a phrase not commonly talked about is something called cubital tunnel syndrome, which acts in a very similar way, but is a different nerve and a different anatomic location. And so we're going to talk about that anatomy. We're going to talk about the unique signs and symptoms that I'm curious about and asking about in an initial visit or evaluation to help me better understand what's going on with you and how this is affecting your life and your quality of life. I'm going to spend some time talking about the non-operative measures that I speak about in that initial visit with every patient, because I do think that there's a role for non-operative management, no matter what degree of symptoms you're having, for how long you've had them. I think there's conservative measures that can be helpful in any setting, and we'll go over what I think those are, and we'll also talk about the next step after that. And certainly we'll leave some time for some questions. If anything comes up that I'm speaking about, please don't hesitate to interrupt me during the talk. I'm happy to clarify anything or go more in depth at that time. So don't hesitate to chime in. I'm going to be using this laser pointer. It's in the center of the screen right now to kind of highlight a few things that I'm talking about. So hopefully you can see that. And so just kind of very briefly looking at the anatomy, it can be pretty complex, but if you break it down on a simpler level, it makes a lot of sense. And when somebody's coming in and is having difficulty with numbness, tingling in their fingers, hands are falling asleep, their hands may be cramping and having an aching pain, waking them up at night. This is the first thing that comes to mind for me. It gives me a lot of information, and typically the first question that I'll ask is not necessarily how long has it been happening, is there an event that triggered it, but really my first question and the thing that really guides me down one path or the other is where is the numbness and tingling? Is it in just one finger? Is it in all of the fingers? And what's the distribution of that numbness and tingling? Does the distribution change? And when I'm asking that question, this is what I'm picturing in my head. These are the dermatomes of the hand, and off to the left side of the screen here with the full body figure, what this is demonstrating or trying to highlight is the dermatomes, which is basically the nerves of the spinal cord as they come out of the spinal cord at the level of the neck and the upper lumbar area. They have these different, they initially start out as nerve roots, which are labeled 2, 3, 4, 5, things like that. Those roots come together to form the nerves we more commonly talk about, the median nerve, the ulnar nerve, the radial nerve. So they form these bundles, and they have a very well-defined distribution of the areas that they cover with respect to movement, motor sensation, and feeling. And so based on the distribution of where your symptoms are, and based on these charts that have kind of mapped out where we expect certain nerves to be functioning, we can further narrow down and identify which nerves are irritated and where they may be irritated. And so if you look at these hands, this is the palmar side, this is the top side. And so the two most common areas of distribution that people come in with difficulty is numbness and tingling in the radial 3 digits, or the thumb, index, and long finger, highlighted in purple here. And you can see that's labeled as the median nerve, which is usually what we're talking about with carpal tunnel syndrome. And the big differentiator for me, usually my second question is, okay, numbness and tingling in the fingers, which fingers? And then specifically, I always ask, is it involving the small finger? And that is very classically, very specifically, both on the bottom and the top of the hand, isolated to the ulnar nerve. And so sometimes it's difficult when you are having numbness, tingling in your hand to differentiate. Is it one finger? Is it all the fingers? Where exactly does the numbness start? Where exactly does it stop? And so there is some crosstalk. There is some gray area. Certainly, you look at the ring finger here, and you see that line goes right down the middle of it. And it's very difficult if you're numb on the ulnar distribution. Well, on the radial side of that finger, sometimes it can be very hard to differentiate that. But this is a good jumping off point. Somebody is having difficulty specifically, mostly with their thumb and index finger. Right away, I'm jumping down the path of median nerve. Whereas if it's specifically, hey, every time I do this, that, or the other thing, it's my small finger that goes numb. Well, now I'm headed down the ulnar nerve pathway. And as we'll talk about later, it sometimes can be both, and certainly in cases of total hand numbness and tingling. So let's start talking a little bit first about carpal tunnel syndrome. So that is classically numbness in this purple area on the palmar side of the hand, involving the thumb, index, long finger, and part of the ring finger. It typically does not affect the top of the hand, but it may affect the top of the fingertips. And why is that happening, or what is exactly carpal tunnel syndrome? The reason that's happening is it's compression of the median nerve at the carpal tunnel. What is the carpal tunnel? So if we look at the hand here, this again looking at the palmar side of the hand, thumb is over here. If we take a cross section through your wrist, right at this level, and we were to look down your hand like a tube, like we were looking down a kaleidoscope, this is what we would see. You can see from this top layer, these structures here, these are the tendons. This yellow structure is the median nerve. Over top of that nerve is a thick ligament called the transverse carpal ligament, and that is the roof of the carpal tunnel. And so we look at this cross-sectional view, looking straight down the arm, straight down into the screen, and what do we see? This is the yellow structure. This is your median nerve. It's the most superficial or close to the skin structure in the tunnel. This thick white band over top is that transverse carpal ligament, causing the roof of the tunnel, and the floor of the tunnel is actually the carpal bones, the bones in the wrist. And what you see, there's a lot going on in this tunnel. It's a small space, and there's a lot of things jam-packed into it. So these bluer structures, these are the flexor tendons. There's 8 tendons here to the fingers and 1 to the thumb, all within that. So we have 9 tendons and a nerve going through this little tiny space at the level of the wrist. And you can imagine, for whatever reason, there can be compression there because of crowding, whether that crowding is most commonly from some kind of inflammation, typically starting around these flexor tendons. If there's inflammation, there's typically swelling. You imagine these tendons, they start at this size, they get inflamed for some reason, whether it's overuse, whether it's an injury, or whether we're not even sure. These tendons swell, and they start to fill up this canal. and they start displacing things. And what do they displace? They displace the nerve, and they start to squeeze it and press on it. And the way the nerve responds to that is by going to sleep or manifesting in numbness and tingling. So if we're having compression here at the level of the wrist, what happens is all of the signals coming from the brain down the nerve get to this tunnel, and now the tunnel is like a traffic jam. So if you imagine the signals coming from the brain are cars on a highway, the nerve is the highway, it gets to this level, and now there's a traffic jam, there's a tunnel or a toll. And those signals are just not getting through. And so these downstream nerves that are going out to the fingertips here, called the digital nerves, which are branches of this median nerve, are now not getting the signals they need from the brain, and that's manifested as numbness, tingling, and it can also start to affect the muscle and cause things like cramping or weakness in the hand. And so you see the main motor branch or functional branch for movement and strength of the median nerve is this, the recurrent motor nerve right here that comes off and supplies the muscles of the thumb here called the thenar muscles. And so not only is there a numbness and tingling component, but there can also be a weakness or a problem with strength. And that's typically in more advanced carpal tunnel. And so when we talk about carpal tunnel, most common statistics, so it is slightly more common in women than it is in men, but not drastically so. The most common age group that I see this setting in is in the 40 to 60-year-old age group, but certainly it's widespread. We see it as young as teenagers, and certainly you see it in patients that are in their 80s and 90s. And so while most commonly 40 to 60 years old, the span is quite wide, and commonly it affects both hands. It's common that people are having symptoms bilaterally. So the one big question I always get asked is, why is this happening? Why me? Why now? Why is this an issue? And really that's an answer I don't always have. We can't always pinpoint a reason or a specific event or a specific trigger that started on the path of this inflammation in the carpal tunnel. And sometimes it's idiopathic or we don't know why. Really, it comes down to this number one thing listed here, anatomy of the carpal tunnel. Going back to that, it's what I call poor design. So we are designed anatomically with a lot of structures going through a small space. And that's a setup for disaster in a lot of different situations. And so there's been a lot of research, a lot of studies trying to answer that question of why. And the reason for that is because this is so common. It's the most common thing that I see in an office day. And so there's been a lot of research, a lot of studies trying to figure this out. And I would tell you that the literature is mixed and that the opinions are controversial. But certainly I think things that stick out in my mind as definite contributors, things I think definitely play a role, vibratory tools. So people that use things that vibrate, classic one is a jackhammer, or somebody that does heavy construction or work with their hands using drills or tools that vibrate in their hands can cause inflammation of the flexor tendons. Jobs or occupations or hobbies that require repetitive wrist and finger flexion. So you think about all these tendons in the tunnel. Every time you're moving your fingers, those tendons are gliding back and forth through that tunnel. When they're gliding, they're rubbing on one another, they're bouncing off of the bones, they're bouncing off of the nerve, and they're bouncing off of this ligament, the transverse carpal ligament. And so the more and more you're doing that, you're generating friction between those structures. Friction generates inflammation, and what goes along with that is swelling, and that starts to occupy space within that tunnel, which is limited. So I do think repetitive activity is certainly involved. Typing is something that comes up very commonly. That is in the wrist flexed position, typically, and repetitive finger flexion and reaching. So those are big ones. Other times that we commonly see carpal tunnel pop up is in pregnancy. And so I would tell you about 20% of pregnancies have some degree of carpal tunnel. And it's usually in the third trimester that we see this, and it's related to the fluid shifts in the body due to the pregnancy, and again, that increased kind of fluid and swelling that can occur during pregnancy. The good news in those situations is usually that after the child is born and the body goes back to a more normal hemostasis, the symptoms typically resolve on their own, but not always. And so that is another common association is pregnancy. Systemic conditions can play a role, and so systemic conditions that are most commonly seen are diabetes or high blood sugar. And so related to that, again, is a proneness or a susceptibility of those patients to have inflammation. And they'll note that at other sites, whether it's a swelling in other joints and a susceptibility to inflammation, tendinitis, and carpal tunnel falls into that realm. The other systemic condition that I always ask people about is hypothyroidism or low thyroid levels. That is another classic contributor that can precipitate swelling and inflammation and lead to symptoms of carpal tunnel. So the main symptoms, I've alluded to them a lot already. So the median nerve is the nerve we're talking about, and it is this purple distribution. So again, the thumb, index, long, and occasionally the ring finger. The symptoms classically are numbness and tingling. So I always say, it's that feeling of if you fell asleep on your hand too long and you had to shake your hands out. Often patients come in and just describe that exact sensation and the need to kind of feel like they need to shake out their hands or wring out their hands to get rid of that sensation. Nighttime awakening is a big one. That's another question that I ask every patient at every visit is about night symptoms. And the reason for that, same idea, going back to the anatomy of the carpal tunnel. If you think how most people sleep in a balled up position like this, and that brings back into play wrist flexion. There's actually been good cadaver studies or studies on patients where they actually put pressure transducers into the carpal canal and measured the pressure in the carpal tunnel in different positions of the wrist. And what they found was that in wrist flexion, there's the highest pressure in the carpal tunnel. Higher pressure means more squeezing on the median nerve and more symptoms. And so most people in their sleeping position are sleeping in a nerve irritating way and may precipitate otherwise mild symptoms that aren't present during the day. So typically, night symptoms can be early carpal tunnel that may progress to become more persistent throughout the day. The end stage of carpal tunnel. So numbness and tingling is often the first manifestation. And as the carpal tunnel progresses, as those nerve signals continue to get held up at the carpal tunnel and are not reaching their end target, which is your fingers and the muscles in your hand, the next development is clumsiness and weakness with grip. And so it does have a motor function. The nerve does stimulate the muscles in your thumb, and that is very important for pinch and grip. And so as that muscle weakens, it's just like if you go to the gym and exercise and you do biceps curls to make your biceps bigger. If you stop doing those biceps curls, you stop stimulating the muscle, all those gains, the muscle starts to wither away or atrophy. The hand muscles are the same if they're not receiving their signals from the brain. And so numbness and tingling is the step number one, and that eventually progresses to atrophy and weakness in the hand. And it's typically involving, or most notable in the thumb, which bothers people during gripping or pinching activities. Holding a key, turning a key, pushing open a heavy door, holding a coffee mug. Things as simple as that during your everyday life you don't think about until it becomes a big problem. Other symptoms that I see less commonly, but certainly are part of carpal tunnel syndrome: swelling in the hands and fingers, just a feeling of fullness or increased size in the hands, and sometimes not only numbness, tingling, or weakness, but also an aching or kind of a dull, uncomfortable feeling that is not only in the fingers, but can also radiate through the wrist, up the forearm, and even up to the level of the elbow. And so the diagnosis of carpal tunnel is often a clinical one. And so it comes down to questioning, relating it back to the anatomy that I alluded to originally. And a lot of times it's a clinical diagnosis. It's something we can go off of by the story that you're telling me, classic signs and symptoms, and also provocative tests that I can perform in the office. And so the diagnosis, classic patterns, if you glance quickly at these hands here, you might say they look normal. And so I wouldn't disagree with you until you start to look a little bit closer. And so certainly one hand is a little bit more abnormal. And if you start to focus, first I would draw your attention here to that muscle on the thumb that I'm talking about here, called the abductor pollicis brevis. This muscle here, you see the fullness here, and you jump over to the other side, and you see a little bit of a hollowing out, or it doesn't look as plump or as full. And it's actually this side that the problem area is. Well, you would say, you just said that there's swelling in the hand and the fingers. Is this side the abnormal side? And although you have the sensation or the feeling of fullness and swelling, typically there's not an actual size difference in the hands that's measurable. And usually what we see, especially in more advanced carpal tunnel, is atrophy of the muscle. And that would look like a decreased fullness or a hollowing out that you can see here when you compare to here, and a little bit into the crease here versus here. And so all of these are clues as to what's going on, and it's atrophy right in this area that points me towards the median nerve in carpal tunnel syndrome. The next step, diagnosis, is clinical signs. A lot of these you could do on your own at home, and see if you could irritate the median nerve. And that's really the goal of these clinical signs and these tests that I do in the office, is to see if I can exacerbate those symptoms, make them worse by irritating the median nerve to further support that diagnosis. The first one and the most reliable one is called Durkin's test. It's this one here in the top right corner. What you want to do is you put pressure right between the two pads of your hand, right here at the level of the wrist crease. You press firmly with your thumb on that area, and you have to press pretty firmly. Sometimes just the pressing itself can be a little bit uncomfortable, but we're not looking for discomfort where I'm pressing. What we're looking for, you press in that area and you hold it for about a minute. During that minute, with pressure, in somebody that has a susceptible median nerve or a nerve that's easily irritated, is an exacerbation or a worsening of the numbness and tingling in that median nerve distribution. And so that is number one. That is physically increasing pressure in the tunnel with your thumb to manifest the symptoms of carpal tunnel. The next, Phelan's test, is probably the simplest one to do at home. And that is where you take both of your hands and you push the tops of your hands together so that your wrists are completely flexed down. Remember, this is the highest pressure in the carpal tunnel. And we do this same position for about 30 seconds to 1 minute. And the same idea, high pressure in the carpal tunnel, also pinching of the nerve at the wrist, should exacerbate or irritate an easily irritated nerve and worsen those feelings of numbness, tingling, sometimes a shooting pain into the hand or the fingers. The last test, Tinel's sign, is similar in area, right between the pads of the hand at the level of the wrist crease. And rather than putting firm pressure there, you tap there. And think about that as like when you hit your funny bone on the table and you get the zing of numbness and tingling down into your fingers. This is trying to mimic the same thing at your wrist. And you tap in that area, and sometimes you get a shocking sensation or an irritation of that numbness and tingling into those fingers. And that's another clinical sign or clue about carpal tunnel syndrome. The last one on here is not something that we can do at home or in the office. It's called an EMG, or a nerve conduction study. And what that is something, it's a tool for me to use to quantify the degree of carpal tunnel. And so this is, like I mentioned, it's not something we do at home. It's not something that I do in the office. But in somebody that has clinical signs and symptoms, whether it is atrophy in the hand, whether it's a classic distribution of numbness and tingling with aggravating factors that we've been talking about, or provocative signs on examination with 3 tests we just talked about, if I'm worried about carpal tunnel and I highly suspect it, something to confirm that diagnosis is this EMG or nerve conduction study. Not only can it confirm the diagnosis, it can also grade the severity of the carpal tunnel syndrome. And the way that it does that is it uses a device similar to this. There's different commercial ones available. It's typically performed by a neurologist or an electrophysiologist. It is an in-office procedure that they perform. And what they do is they use a device to stimulate the nerve electrically. And they stimulate the nerve at different levels throughout the upper arm. And they're stimulating the nerve along its full course. They use electrodes on the hand to measure those responses. And really what they're measuring is the time it takes for the signal or the stimulation to go from point A to point B. And that is something that we can measure in typically meters per second. And we have a baseline. These studies or these tests are done on patients that have no symptoms, no signs of carpal tunnel to establish what is quote unquote a normal conduction velocity. And typically we're talking about 4 to 4.5 meters per second or less being normal. And so when we perform this test on somebody that has carpal tunnel, those numbers increase. Or thinking again back to the traffic jam, the signals are taking longer to get to their end target. And so they slow down at the tunnel, the traffic jam at the tunnel can't get through, and those numbers increase. They go to, and rather than being less than 4, they go to 5 or 6 or 7 or 8. And based on that, the degree of slowing, we can grade or judge the severity of the carpal tunnel as mild, moderate, or severe. And that is a lot of helpful information. It helps me to determine not only confirming the diagnosis, but also to determine what to best recommend for you as far as treatment. Whereas a patient with symptoms that they've had maybe for a month or two and mild EMG findings, conservative management is much more likely to help make a lasting difference and maybe even be curative for carpal tunnel. Whereas somebody that has had more long-standing symptoms, say they've had numbness and tingling for a year before they came to see me, and their EMG shows me moderate to severe carpal tunnel, well, that makes things a little bit more difficult. It makes the non-operative or more conservative measures not as likely to be effective. Certainly, I always recommend trying them because you never know what kind of results you'll get. But it does alter my discussion and says that, you know, these things are worth trying, but you know, we have to be prepared that they may not work. And so after that, we start to talk about treatment. And a lot of these things can be done at home and can be done without an office visit. And a lot of these resources are available to you over the counter without a prescription. The simplest and always recommended is activity modification. And I say simple in that it doesn't cost anything and everybody can do it. But in a similar sense, while it is simple, it's also challenging. And so it's very easy for me to say, well, if it bothers you, don't do that. But you know, if doing that means doing your job or doing the hobby that you love, or doing your activities of daily living required for you to survive or perform personal hygiene, it's not something that you can simply not do. But on some level, there are some measures that you can take to try to avoid exacerbating factors. What can those factors be? And so talking on the phone is something very commonly that I talk to people about. Typically, your elbow and your wrist are in a flexed position when you're talking on the phone. So using a Bluetooth or headphones for that can help eliminate that. Paying attention to how long you're at the computer, how long you're typing for. Can be different things like that. So paying attention to exacerbating factors, figuring out every time I do this, that, or the other thing, my symptoms come on or they get worse, and trying to avoid those activities as best you can. I always talk about anti-inflammatory medicine. It is something that makes sense clinically. We've spent a lot of time talking about this as an inflammatory problem. There's, for some reason, whether it's a systemic problem, an overuse activity, driving swelling, inflammation, you would think that anti-inflammatory medication would help, and that makes certainly a lot of sense to me. But I think it's something that often does not work very well. I think it's worth a short try. Medications like ibuprofen or Aleve theoretically should make a difference, but to be honest with you, it's not something I recommend long term, and is often something that I don't see great results with. certainly activity modification is something I see better results with. And something that is simple and readily available, and really the biggest recommendation, and something that I have every patient with carpal tunnel signs or symptoms do, is to get a splint. And this is a picture of the splint. There's tons of them that are commercially available, whether it's on Amazon, online, anywhere, or at your local drugstore. They have them right on the shelf. And these are called cock-up wrist splints or carpal tunnel wrist splints. And what they do, the goal is this center pad here. You can see within this leather case, there's a firm or a metal rigid bar right here that prevents wrist flexion. The rest of it is soft, adjustable with Velcro. And what it does is it spans across the wrist and holds it in slight extension to prevent wrist flexion. And the idea behind that, again, is the highest pressure in the tunnel is during wrist flexion. If we avoid that, we're maximizing the space in the tunnel, giving the nerve the most room. When it comes to splints, interestingly, I always recommend that patients wear them only at night, which is a good thing because a lot of people say, hey, I can't wear a splint to work, or it's going to get in the way of my daily activities. And I completely understand that. And the good news is that the recommendation is to wear these splints only at night when you sleep, trying to avoid this curled up position to keep the wrist straight. It typically is not going to interfere with your activities at that point. And so there's been good research that they looked at patients across the board with established carpal tunnel syndrome and splints. They had some patients wear them just at night, some patients wear them just during the day, and some people wear them around the clock, day and night. And the patient group that did the best were the patients that only wore them at night. And so while there's not an exact science reason for that, my thought is at night, you're taking pressure and opening off the canal. You're giving the nerve time to breathe, time to relax, and decreasing some inflammation over that 6, 8, 10 hours, however many hours you're sleeping. And so that you can notice those benefits during the day while you're not wearing the splint. So a splint is something I recommend for everybody, regardless of degree of carpal tunnel or severity of symptoms. It's something that works, has been well established, and is very simple and in an inexpensive way to try and get this to help. The next thing is therapy, whether it's therapy exercises at home or whether it's therapy exercises with a certified hand therapist or a hand therapist. And this is just one example. This is something I give to all of my patients that are having surgery or are having difficulty with carpal tunnel syndrome. And it's, the focus down here, this is the progression of tendon gliding exercises. And the idea is with the fullness in the carpal tunnel, you start to get those tendons sticking to one another. That inflammation makes the tendons kind of full and want to stick together and cause friction. And so by loosening up the canal, getting those tendons gliding together, doing simple exercises that stretch and move those tendons together can help relieve some of these symptoms. This is kind of the most basic form of this. There's a whole therapy regimen that a hand therapist can go through, exercises to do at home, different modalities for swelling control. And so I do think therapy can play a role here and can be helpful, certainly in mild symptoms or in symptoms that are early on, that have only been present for a few months. And so that is certainly something on the treatment algorithm. And then as far as the next steps, we're getting out of things you can do on your own or at home at this point. But really the next step is injections. And so you hear about injections for things like arthritis, injections in your knees or your hips. This is different. And so injections for arthritis are not curing the problem. They are targeting inflammation in those areas generated by the arthritis, but they are not restoring the cartilage to the bone or really solving the problem, but really they're just kind of masking the symptom and the inflammation. Here, the problem is inflammation. And so there's not a bony problem here. And so in mild cases, carpal tunnel injections of steroid can be curative. And so there's been literature that looks at this quite a bit. Certainly not every patient that comes to see me with signs and symptoms of carpal tunnel is appropriate for an injection. Patients that have been demonstrated to have the most benefit from a carpal tunnel injection are patients that have had symptoms for less than 6 months. So I call that early carpal tunnel as far as the duration of symptoms. Younger patients, typically the literature would support 25 to 30 years old, so much on the lower end spectrum for age. And for some reason, females. So it's young women with symptoms less than 6 months have shown the best response to cortisone injections as far as symptomatic relief and getting a carpal tunnel and actually being curative. That being said, I do think there is a role for carpal tunnel injections outside of that demographic, outside of that narrow box. Injections can be not only therapeutic, but they can also be diagnostic. And so in certain patients, I'll recommend a cortisone shot. And one of the reasons for that certainly is therapeutic. We're trying to get rid of your symptoms and hoping that they don't come back. And so it can try and decrease, again, that inflammation in the tunnel, get those symptoms to go away and hopefully not come back. It can be diagnostic in a sense too. It can confirm my diagnosis. If I were to give you a cortisone injection and say it's a mixed picture, say the numbness and tingling may go into your small finger as well, which doesn't fit inside the carpal tunnel syndrome box. It's a little atypical. But say I'm considering different options, but I do think carpal tunnel is likely. An injection, if it were to relieve your symptoms, even if only for a short time, 1 week, 2 weeks, or even a couple months before the symptoms return, that is diagnostic for me. That tells me, yes, we're treating the right thing. We put an injection into the carpal tunnel, the symptoms resolved for some time and came back. So it's the carpal tunnel that is the issue. And so in a sense, an injection can be not only therapeutic, but also diagnostic. There's also been good literature to support that patients that respond well, even if it's only short term to a carpal tunnel injection, would benefit more so from surgery than those that don't. And so somebody that comes in, say they've had, for example, they tell me numbness and tingling in the thumb and long finger now for 2 years. And the symptoms started intermittently and now have become almost constant around the clock. It's bothering them at night. But it does involve their small finger as well. And they've tried some splints, but it hasn't worked. That patient is a good candidate first for an EMG and a nerve conduction study, but also for an injection. And the reason being is I provide the injection, I tell you to keep an eye on your symptoms, and hopefully they resolve. And if they do resolve and stay away, then that's the end of the pathway. But unfortunately, if they do come back, say 3 months later, well, hey doc, the injection worked great for 2 months, and then all of a sudden I started to feel that numbness tingling, and now it's back right to where it was before the shot. Well, I can tell very reliably to that patient, a carpal tunnel release surgery is something that's going to work really well for them. The shot is mimicking what that surgery is going to do for that patient. And so I can tell them very confidently that an operation is something that they would benefit from. So when conservative management has failed, when all of the options we just spent some time talking about are not working, and you say, hey, you gave me an injection and it only lasted for a couple days. I've been wearing this splint at night and it's not helping me. I'm still waking up from sleep, and I can't get through my daily routine. I can't get through my work day. My fingers are aching. They're numb. I'm dropping things. We get a nerve study. We confirm that it's carpal tunnel syndrome, and then we talk about the next step. And the next step sometimes is surgery. And so when it comes to recurrent or persistent symptoms despite non-operative treatment, the next step is sometimes an operation. Patients that commonly in the back of my mind, I'm telling myself early on that their EMG is likely to be moderate to severe are patients that have constant numbness or have already developed weakness in the hand and they're dropping things, or certainly if they have that atrophy or loss of muscle mass in the hand, that tells me that likely they have more advanced carpal tunnel, are less likely to respond to non-operative treatment, and may need to progress more quickly on that pathway towards an operation. But certainly in all instances, non-operative treatment is recommended to start. So just briefly, I wanted to go over what the operation was and what it is and the way that I do it. So classically, carpal tunnel release is a mini open procedure where we use an incision similar to this one. It's about 2 to 3 inches long in the base of the palm, and we cut through the skin, the soft tissue, get down, and we come down on the roof of the carpal tunnel and open the ligament under direct visualization and release it along that length. That is the classic tried and true way. I still do it this way on occasion for various reasons, but I've kind of graduated more so to doing much more commonly, probably about 80 to 90% of the time, something called endoscopic carpal tunnel release, where I use something very similar to this drawing here. Rather than the incision being down into the palm, I stay out of the palm and I make an incision transversely at the level of the wrist. Here I'm avoiding the pillars or the pads of your hand and in an attempt to decrease soreness in that area and avoid the palm of the hand. And so this incision, rather than being 2 to 3 centimeters, is typically only 1 centimeter, so it's about a third of the size. And here's a real life drawing of it about right here. It's at the level of the wrist crease rather than being down here in the palm. The way I complete the surgery is I cut the ligament from the inside out using a specific device designed for this. And so we put a camera into the middle of this device. It slides into the middle of the device so that I can see where this is. And I make make this small incision here. I insert this device underneath the skin. It goes underneath the carpal ligament right here, the transverse carpal ligament. This is looking at it from the long end, and this device at the end of it has a knife that is originally recessed below the surface, and when I push this button, it deploys the knife, and then as I pull the cannula back out under direct visualization, I cut the ligament from the inside out. And these are actually clinical pictures of me doing the procedure, and this is exactly what I see when I do an endoscopic carpal tunnel. Here is a diagram from the guide of the training tool. So when you first put the camera in through the skin, what do you see? Here, rather than cutting the ligament from the top down, we're coming from the bottom up. So we're inserting the device into the carpal tunnel and looking up at the roof. And so here is a drawing. You see this band structure here, and that is the transverse carpal ligament. We're looking up at the roof. Here is a diagram of the knife of the device being deployed. Here's the walls of the device that are containing that knife, and me retracting the blade so that it cuts and opens the roof, and at the other side of the roof we see this yellow fatty material in the palm of the hand. And so here's exactly what I'm seeing when I have the camera. The camera is at the one end of the device. You can barely see the knife right here, recessed within this plastic cannula right here that does not have a roof on it. The roof is these white fibers of the transverse carpal ligament. When I get to the end of the ligament, which is right here, I deploy the knife and then I slowly pull the cannula backwards. Here you can see I've started to cut the ligament. The majority of it's still intact. I start to cut it here. I visualize the fat in the background so that I know that I got the whole ligament. And then again, under direct visualization here, I retract the knife and I cut all the way along until all I see is fat. And on either side of the cannula, I see a ribbon here and a ribbon here. And those are the 2 leaflets of the transverse carpal ligament that have now been cut and retracted. And now there's no roof over the tunnel. And on this cannula, if you look at it here, the sides of it are clear so that I can see through it. And over here, what you're seeing, this structure right here is the median nerve. And so that way I know that I'm not injuring the nerve because I can see it and I keep the blade away from it. And so this is endoscopic carpal tunnel release. It allows me to do the same procedure as here with a smaller incision, avoiding the palm of the hand. The incision is closed with 1 absorbable stitch beneath the skin and glue. And typically I recommend a bandage only for 3 days, after which you can remove that bandage, begin to shower, and just keep that area clean and dry with a Band-Aid until you see me in the office. And so we've come a long way, I think. And I think this is a great procedure, and there's literature to support its effectiveness. And so that is carpal tunnel. Quickly, I do want to leave some time for questions. I quickly want to go over cubital tunnel syndrome. A lot of the same principles that we just discussed. However, it's very similar, other than we're talking about a different nerve in a different location, but all the principles are the same. So remember, carpal tunnel syndrome is the median nerve at the level of the wrist. Cubital tunnel manifests in a very similar way: numbness, tingling, nighttime symptoms, having to shake your hand out, an achy, crampy pain in the hand, but typically it involves the ulnar or small finger side of the hand, classically the small finger and half of the ring finger. The reason the nerve is getting compressed: in the wrist, it's the transverse carpal ligament. Here on this picture, you see a variety of reasons. The nerve is here, it's this structure. Anywhere along this course, which is about 15 centimeters long, from the epicondyle, or the big bump on the inside of your elbow. We're talking about the inner side of your elbow here. The funny bone nerve is the ulnar nerve at your elbow. When you accidentally bump your elbow on a hard surface and you get that shock down into your hand, that is the ulnar nerve in the cubital tunnel. And so anywhere along this course, any of these structures, something called the arcade of Struthers, the medial intermuscular septum, which is on the edge of the triceps. The cubital tunnel itself is a defined structure which has a ligament very similar in the wrist to the transverse carpal ligament, called Osborne's ligament. Right here, between these two muscles, which are the big muscles here, the flexor carpi ulnaris muscles. And what this arcade, or this tunnel does is, it, for similar reasons, pushes on the nerve at the level of the inside of the elbow and manifests as numbness and tingling down in the hand. Those clinical signs and symptoms we talked about. For carpal tunnel syndrome, we look for hollowing out of the thumb muscle on the palmar side. With respect to the ulnar nerve and the cubital tunnel, that muscular distribution typically is on the back of the hand. The most common site that we see it is between the thumb and the index finger in the web space here. You compare this side to this side, there is a hollowing out right here, or a loss of muscle due to weakness. And the nerve being pinched, those cars on the highway not getting to their destination, and the muscle not being stimulated. Similarly, numbness, tingling, weakness with pinch or grasp. Here you see weakness and pinch, and pain or sensitivity on the inner side of the elbow. This is a more extreme picture of the atrophy or the muscle loss that can happen in the hand. Not only does it affect the first web space and the pinching here on the back, it also starts to affect the spaces between the fingers, making the finger bones and the tendons more prominent. And this is the interosseous muscles, or the intrinsic muscles of the hand, that are helpful for this motion, fingers in and out, or abduction and adduction. The clinical signs, very similar: a Tinel sign, which is a tapping on the inside of the elbow, right below that big bump called the medial epicondyle. What you're doing is you're tapping right on the nerve. And really the simplest one to do at home is called a flexion compression test, where you maximally flex your elbow and hold it up to your shoulder like this, or in the picture here, and you put your finger right over the nerve on the inner side of the elbow. Holding that for 30 to 60 seconds can generate those similar symptoms, and what we're looking for is development of numbness and tingling down into the small or ring finger. Very similarly, with a suspicion of cubital tunnel syndrome, or perhaps a mixed picture, EMG and nerve conduction testing is very similarly helpful. What are the treatment options? So conservative measures for carpal tunnel are tried and true. Splinting works very well. Activity modification is the big one for cubital tunnel. Carpal tunnel syndrome, we talk about splinting as being the most effective, tried and true. I recommend it to everybody, and it's easy. As far as splints for cubital tunnel, it's certainly an option. There's products available which provide a rigid splint. The problem is that the splint has to keep the elbow extended. The maximal pressure, very similar to the wrist, the maximal pressure in the elbow is when the elbow is flexed. Again, times that you experience that: talking on your cell phone, driving in your car, sleeping at night. Elbow flexion, you think about increased pressure in the tunnel and pressure on the nerve. Splinting can help with that in a similar way, maximizing the space in the tunnel. However, You can imagine walking around with your arm extended or trying to sleep with your arm out can be quite difficult. And in my experiences, splints are very poorly tolerated, whereas a night splint on the wrist tends to be much better. Activity modification is the big one, avoiding excessive elbow flexion. One way to do that that is more easily tolerated than a splint here is something as simple as a padded elbow brace you see down here that you may get with the pad on the back, typically is for its design. If you were to get that pad, it's called a heel bow or just a padded elbow brace. And rather than wearing it as designed, what you do is you put the bulky padded part and you flip it around. So you flip this into the bend of the elbow so that it's sitting in the crease of the elbow, and that fullness blocks you or prevents you from hyperflexing at night and can help. Anti-inflammatory medication, similar, theoretically should work, but often don't see great results. And another big difference here, injections typically are not recommended for this as they are in carpal tunnel. Similarly, there is operative management should non-operative management fail. This is a procedure that I do open. There is an endoscopic version of this that I don't recommend or not a procedure that I perform. I tend to like to look at the full course of the nerve through the elbow here, which I think is difficult through an endoscope. And so I do an open incision. And just in closing, I'm almost out of time, is other causes. And so commonly, carpal tunnel 50% of the time can be bilateral. Occasionally, you can have symptoms not only in the median nerve, but also in the ulnar nerve distribution. And it's not uncommon to have both carpal tunnel and cubital tunnel if you have numbness and tingling symptoms that are bothering your entire hand. Another mimicker of these, I call carpal tunnel and cubital tunnel peripheral compression. Another big thing that's always on my differential, always something in the back of my mind, hey, why is our conservative measures not working? Is it pain in the neck? And so patients that have pain or cramping in the neck or history of neck issues, there is something called cervical radiculopathy, where the nerves, as they come out of the neck, those nerve roots, before they form the peripheral nerve or the median or radial ulnar nerves, can be pinched at the level of the neck and manifest very similar symptoms distally all the way down in the hand, although the problem is at the neck. And so that is always something that we're asking about and being aware of. As far as COVID-19, things have changed quite a bit in the last week as far as the regulations in the state. And so I just wanted to let everybody know that we are open and we're here for you if you're having struggles, if you're having difficulty. So hopefully some of these home remedies, some of these commercially available online at your drugstore remedies may be helpful to you, but if they're not and you feel like you need something more, we're here for you. Our office locations are open. I'm in Medford, Moorestown, and Voorhees. And we actually resumed elective surgery within the last few days as well. And so we're getting much closer to a normal practice pattern as far as scheduling. That being said, we are taking full precautions as far as patient safety and staff safety. We're spacing out our scheduling and our scheduling times to keep everybody safe and healthy. So I hope this was helpful. Please let me know if there's any questions, anything I can clarify or answer, and I appreciate your time and for you joining us. Thank you very much.
Thank you, Dr. Smith. This was a wonderful presentation. We'd like to open it up for questions now. You can feel free to use the chat box to send your questions. If you could send them to everyone, or if you feel more comfortable unmuting yourself, you can go ahead and ask your question. Let's just make sure we don't have more than one person speaking at a time. I'm gonna give it a minute or so just in case somebody's typing. I don't want to cut anybody off.
While we're waiting, this is my dog Lenny. This is my son Will. Favorite Binky. This is his Kiwi, and this is my wife Stephanie. We like to vacation down the Jersey Shore in Seattle.
Beautiful. Well, I don't see any questions coming in. Again, I wanted to thank everybody for joining us tonight. This session has been recorded and will be up on our website. Oops, no questions, but so cute. This is from Lori.
Thank you very much.
Thank you, Lori. Again, so this session has been recorded and will be on our website sometime next week. Again, thank you for joining us, and thank you, Dr. Smith, for taking the time to be with us tonight.
Thank you, everyone. Have a good evening.
Thank you. You too.